everybody. Thanks, Susan. And a special shout out to Robin. I saw you're in the audience, or someone's using your computer, so we miss you. Hope everything's healing well. So, inflammation and pain in the oral cavities. Yes, I am a dentist by trade, but as life has gone on, I have become a big advocate for senior pet care and taking my International Senior Vet Care Society to a different tangent. I'm going to try to build a website, resources, just overall senior pet care, taking resources from everything, from all the different fields of different companies, different products, you name it. So we can provide better comprehensive information on senior pet care. And one of those things is certainly going to talk about dental pain with our senior pets, but with all of our pets, because as we look at oral and dental disease, we usually have discomfort and pain. Today, we'll be talking a little bit about periodontal comfort, the pain we see with fractured teeth and tooth resorption, certainly when there's ever any trauma, and sometimes when you see chronic pain as well. Part of that management will be during the operative time, so we'll focus on that later on. The thing of it is, if you ever ask anybody if they've had a toothache, oral pain, usually it's not with fond memories. That's because the nerves in teeth are a little bit different from everywhere else. They tend to primarily have the A delta and C fibers that are most impactful. And while they can sense heat, cold, and pressure, the one thing that the brain perceives is pain. So if you can feel some tenderness when you drink something hot or you drink something cold, you're actually not feeling the cold or the heat, except for your gum tissue can, certainly in your mouth. The tooth registers pain, which is a pretty good defense mechanism for any stimulus that might be causing those nerves to transmit. When we look at periodontal disease, usually we consider this more of a silent disease, not a lot of acute pain typically, because you've seen those pets with those horrible mouths that are still eating. They don't seem that uncomfortable unless there's a loose tooth, or I've seen upper fourth premolars on cats turn sideways and then they can't close their mouth and they're uncomfortable that way. But generally speaking, since it's a fairly slow progress, we don't have acute pain unless those ulcerative patients, such as stomatitis cats, the little white dogs with ulcers, then those are painful. The key of it is, along with pain, we also talk about infection and sometimes that bacteria that gets in the bloodstream. Well, I want you to think a little beyond that and think about the chronic inflammation. And it's probably that inflammation that impacts systemic health more than anything else. In fact, inflammation impacts aging. So I really like you to focus on inflammation as well. If a patient breaks a tooth, if a dog crunches on a antler and breaks that upper fourth premolar or knocks his head with his housemate and breaks a canine tooth, initially when that pulp is exposed, it's extremely painful. But the nerve in that pulp dies within a few days. You might see some bleeding still, but that's usually granulation tissue with the blood supply still present for a bit. After the pulp is dead, the tooth is fairly innocuous. There's not a lot of discomfort there, unless there's a rough edge or the upper fourth premolar has a slab fracture and that's rubbing around, moving around. Occasionally, we'll see chronic abscesses that drain out or chronic abscesses that kind of build up. And in people, because of the structure of their roots and their face and everything else, they can have a quiet infection going on and all of a sudden get what's called a phoenix abscess, where it causes extreme discomfort due to the pressure. I'm not sure we've seen that too often in dogs, but you may have noticed a dog with a broken tooth not chewing on that side as much. So they may show some discomfort, if not acute pain. Now, tooth resorption, TR, they've been renamed TRs. The odontoclastic, what we used to call FORLs, is the most common type of tooth resorption we see, and particularly in cats. We do see resorption in dogs. A lot of times they're still in the roots, but whenever this inflammation gets an extension into the crown, and then we start seeing the gingiva growing into that defect. That's where these teeth become painful. So when we first have resorption in the roots, whether it's a cat or even a dog, if it's confined to the roots, we generally don't have too much problem. But once it's extended into the crown, then we get the discomfort. Now, a smaller percentage, maybe 5% of cat and tooth resorptions are inflammatory, type 1. That's where we have periodontal disease, inflammation, and now the exposed root gets resorbed due to inflammation, and that can be uncomfortable as well. Certainly, the trauma itself causes a lot of pain, although you'd be amazed at how dogs come in with, and cats even, with significant trauma and still are walking around and seem pretty stable. Having the pieces float around and get knocked about isn't terribly comfortable either. So when we look at trauma to the facial structures, not only do we have to look at, is there any bone fracture? Is there a jaw fracture? But we have to look at the teeth that are incorporated within that fracture site when we're deciding on how to treat it, how to manage it, if we can stabilize it. Or on some older dogs, when I have pathologic fractures, sometimes we take that section out. We can also see TMJ injuries, primarily with luxation, but sometimes with fractures. And while the luxations can be reduced fairly simply early on in the process, you can still have some osteoarthritis problems in that TMJ later on. So it's something you have to watch for when the pet ages. Any soft tissue avulsions or tears certainly need to be treated and fixed, but oral trauma can cause a lot of discomfort. Now we're going to go to some more chronic diseases. And with our ulcerative diseases, I already started to mention cats with stomatitis, feline chronic gingivostomatitis. When we have the little dogs with the contact ulcers of the buccal mucosa, we call it contact mucositis. Basically, in these patients, the patient's immune system, the host immune system, is overreacting to whatever plaque and food and material and calculus is on the tooth surface. In cats in particular, we are going to be looking at the caudal mouth. If we have inflammation in the caudal mouth, we're usually going to talk about full mouth extractions, and we'll chat about that in a little bit. Whether it's a little white dogs with the ulcerative Maltese stomatitis or bigger dogs with chronic ulcerative periodontal stomatitis or chronic ulcerative contact kissing ulcers, we know we have to deal with both the teeth to remove the plaque and calculus, but it's usually more than just cleaning, and these patients can be very uncomfortable. Oral tumors, we would think at times that they're not that painful because we see dogs and cats come in with huge tumors that went unnoticed until they're literally growing out of the mouth or bleeding. But when you do have that excess of tissue and the patient can chew on it if it's too large, or if we have a space occupying mass in the bone, then these certainly can be painful with a lot of inflammation involved as well. So as we're looking at this, I may be looking at going with a little bit more than just an NSAID, maybe look at piroxicam, and we'll look at some choices later on. Now here's an interesting syndrome, the feline oral pain syndrome, or FOPS, F-O-P-S. While any cat can typically have it, it really is predominantly found in Burmese cats and kittens. It's a neuropathic type of pain disorder because the trigeminal nerve is desensitized by different triggers. And that trigger can be the eruption of teeth in young patients, and then periodontal disease or tooth resorptions in an older patient. It can also be triggered in a patient by stress. So we need to watch out for these cats in particular. Then sometimes we'll have chronic pain that we just can't determine exactly where it's coming from or why it's happening. Dogs that will paw at their face, grind their teeth, rub their face against the ground. Now, certainly when we see chronic oral disease, a neuropathy is always a possibility because the nerves are so close. If we have to do extractions, close an oronasal fistula, the nerves are always very close to the area that we're doing surgery on. There could be dysplasia or osteoarthritis with the temporomandibular joint. Thing is, don't just look at the mouth. Also really examine the neck and the ears See if there may not be some pain more in that area, and the dog can just get to the mouth easier. So watch for that as well. I've had some older dogs that had longer hair, especially when we took out many of the teeth, that they would get the hair in the mouth and it would get caught. So we keep them trimmed back. And then with some, I think we have a little OCD, some behavioral issues going there. But no matter what, we need to see how to make them more comfortable. So those were our types of pain that we see. Now we're going to start talking about how to manage oral and dental pain. Starting with surgical pain management. We are going to be looking at multimodal, multi-step therapy. We're going to go with some preoperative analgesia. We're going to be looking at sedation on patients that need it. On this preoperative, we'll probably go with an opioid, probably a benzodiazepine. We might need an NSAID to bring down the pain and inflammation. We might use alpha-2, and we've been using meropenem on a regular basis as well. So when you look at the opioids, they work really well in combination with a tranquilizer or sedative preoperatively to help start fighting that pain. Certainly with the morphines, with a full mu agonist, it's a very useful product in our practice. We use hydromorphone. Fentanyl is very potent, but has a short duration. And I'm a little bit leery about using some of the patches and everything, and then even how they react to it. Certainly buprenorphine, we use quite a bit, both short acting and with the longer acting ones. And we even use it in our blocks. We'll talk about that in a bit. Butorphanol does help a little bit with pain, but it's more about sedation. It doesn't last very long with analgesia. And the opioids, we can also use in CRIs. Now, for my patients, if it is appropriate, if they have good renal function and there is inflammation and discomfort, I'm certainly going to reach for some kind of NSAID. If I do have any renal concerns, then I might hold back on that until after the recovery period, or if it's really severe, if they've had any issues, then I might avoid it. But there's many good choices. I just have a picture of one up here. Now, I mentioned piroxicam earlier with the tumors. So if I have a patient that has a tumor, either for an operative patient or maybe one that the tumor is too big and we really can't even debulk it for palliative benefit, then I'll probably switch over to piroxicam for these patients. And a lot of times I'm going to have to compound this because 0.3 mg per kg, to get the smallest 10 milligram human dose, you have to have a pretty good sized dog, around 70 pounds. But I do like to use this once a day, and then I just watch for stomach upset too. But watch for, remember, inflammation is a big part of dental disease. And we love our alpha-2s. There are some of my older patients with some cardiac issues. I can't use it as much, but using in combination with the opioid and even the sedative, I'll go with a fairly small dose and typically don't have any problems, but I do avoid it with my cardiac patients. I can reverse it. I can reverse it partially. I can use it after a procedure if they're gator rolling on you to help really get them back to a quiet mode. But I think with those small amounts, those minute amounts, we can get a much smoother anesthetic plane. It helps with the pain. We're just going to monitor the blood pressure, you know, the heart rate, make sure everything's going okay. If we have concerns, we can reverse it. For those of you who may not have seen it, on YouTube, there is a dexdomitor remix. A clinic put together a song and they did an amazing job of it. It's quite the foot stomper. So on our surgical patients, if they have Cerenia, they can give it home. We have them give it the night before. If not, we try to get it in at least 45 minutes prior to the procedure. So as they're coming in, getting their initial exam, we usually give them the Cerenia. We have switched to using 20 gauge needles to give it, and they don't seem to mind it as much. So there's a hint. Not only will this help us decrease the nausea that the hydromorph may cause prior to surgery, but it'll also make them more comfortable afterwards. They show smoother recovery and less use of inhalants. So we've been using Cerenia on pretty much all of our patients preoperatively. Once we've got them under general anesthesia, and remember, our inhalants and our induction agents do nothing for analgesia. We don't box anybody down these days. When I'm looking at pretty much any surgical procedure, anything beyond cleaning and polishing, certainly extractions, trauma repair, tumor removal, ectomies, but even if I'm going to be doing some root planing, that can cause some sensitivity. I'm going to look at putting a local or regional block. The main thing is, especially with small dogs and cats, I'm going to watch my total dose, because I want to make sure that they stay comfortable through the procedure so I can keep my inhalant anesthetic as low as possible. And then through recovery, these blocks are still working. So we look at the local regional blocks on that pain pathway, transmission and transduction. Again, decreases the general anesthetic need. We have a smoother recovery. And we can also look at using some longer acting local anesthetics so we can maintain that comfort level through the postoperative period. So what do we use? Lidocaine is a good local block. It works pretty quickly, but it doesn't last as long. So I tend to get bupivacaine, and I just make sure I get it in 5 to 10 minutes before I'm doing my work. So we can be taking x-rays, determine what we need to block, finish up with the cleaning, and then that block is already in place by the time I'm ready to start surgery. I prefer the bupivacaine 0.5% if I can get it. I love it with the 1 to 200,000 epi because it increases the time it's in there, decreases bleeding. It's hard stuff to find though. If you have any cardiac issues, arrhythmia issues, you don't want the epinephrine, so you go to the plain bupivacaine. My maximum dose is going to be 1 mg per kg for cats, 2 mg per kg for dogs. Measure out your total amount. An 11-pound cat is going to be 1 cc. Don't use any more. All right. Now, as we look at using the blocks, some people have advocated doing a mixture of lidocaine and bupivacaine to make it work faster and last longer. But studies have shown that the lidocaine just basically dilutes out the bupivacaine. So I like sticking with the bupivacaine by itself. Now, to make it last a little bit longer, there's a couple things we can do. I do like using Nocita. It's not labeled for dental blocks, but I've used it quite a bit. And basically about the same volume, cats and dogs. The release is gradual, so your analgesia is going to last up to 72 hours. Now, they do have the smaller 20 ml vials, and I'm only in practice 2 days a week now. I'm not doing as many cases as I do, so I can't use that all the time, but we have some for our maxillectomies, and we really like it for our full mouth extractions on kitty cats. If you're not able to have Nocita in the practice or don't have some available, you can do 1 part buprenorphine, say 1/10 of buprenorphine, take 9/10 bupivacaine and squirt the 9/10 into the syringe with the 1/10 buprenorphine. And it can extend that analgesia 24, even up to 72 hours, variable depending on the patient and the block itself. So we have ways to potentiate the Marcaine block that makes it last longer and makes our patients more comfortable. So just a brief overview of intraoperative blocks. Training is required. I would recommend getting skulls. Now, don't type in skulls and hit search. I'd go to Skulls Unlimited International. They have a very good supply. I'd recommend getting 1 dog, 1 cat, and if you can get a brachycephalic dog, that's a different species. I'd like all 3 of those so you can tell where you need to block. Sometimes you can show owners where the teeth are crowded on the brachycephalics, or if you have to do a mass removal, how much you have to take back. So they're very helpful teaching your staff, teaching your clients. Now, I prefer doing the regional blocks, but if I can't, then I'll look at local infiltration. As long as you get it around the nerve, around the site that you're going to be doing the surgery, so you can provide analgesia. Now, many people are used to doing an infraorbital block where you come from the rostral aspect of the infraorbital canal. And as such, you're not supposed to advance your needle any further than the medial canthus so you don't inject the eye. You then hold it, rotate, pull back, make sure you're not in a vessel, and slowly infiltrate. In theory, using this deep method or even using a catheter, you can deposit local anesthetic at the caudal aspect of the canal, which is the pterygopalatine fossa. You keep your needle from going into vessels, hopefully, and into nerves, and get that material in there. Look at a brachycephalic skull. Think about a cat skull. How far is that infraorbital canal, and where's the eyeball? So it's pretty difficult to advance it in certain patients. If you infiltrate just rostrally and put some pressure, then you're probably just going to get soft tissue rostral for that one. So I like to come a little different way, looking at a caudal block. Now, there are some descriptions of doing a caudal block by placing your needle behind where the molars are and advancing your needle to try to get towards the pterygopalatine fossa. The thing of it is, without a direction forward, there have been accounts of globe damage, inoculating the eye, putting the local in the eye. So what I like is a different approach. I come from the back of the head, from underneath the zygomatic arch, behind it. I keep my needle and syringe parallel to the palate, so we're not sticking up into the eye. I walk it behind the zygomatic arch. I advance it forward toward that palatine fossa, pterygopalatine fossa, kind of directed toward the opposite nose. This is where having a skull in front of you is really helpful to kind of determine where you need to be injecting this. So not only will this get at the caudal aspect of the infraorbital canal, but these molars back here, first and second molars, aren't innervated by branches coming out of the infraorbital canal, and sometimes the upper fourth premolar isn't. So by infiltrating as you withdraw your needle, you'll now get those caudal teeth, those distal teeth. Right, the other one is mental block. I just like the name of it. Sometimes in a larger dog, I can actually get a small needle into the middle mental foramen that's usually underneath the second premolar. And if I can gently get it in there and infiltrate a good amount, then I'll probably get better blockage for the incisors and possibly even the canine teeth. But this is pretty variable. So be ready if you need to do a deeper block for the entire mandible, or when your surgery site is open, heart rate goes up, blood pressure goes up, infiltrate some around that area directly. If you do need to block the entire mandible, you can get to the caudal aspect of the mandibular canal through an extraoral approach through the skin or intraoral approach through the mouth. Just remember that opening is difficult to palpate, but it runs on a line between the last molar and the angular process. And you can either advance a needle through the skin from outside or even place it intraorally. This should impact the entire mandible, but if you put a lot of material there, it could leach out to end up infiltrating the lingual nerve. So just monitor closely post-operatively. Like I was saying, if you've got a block in, or maybe you can't do a good regional block because there's inflammation, or you pulled back and there was blood, so you don't want to go back into the same area that you hit a vessel, at least infiltrate some of the block in your looser alveolar mucosa above the site. In fact, if you got the Marcaine with epi, that'll help with your bleeding as well. And then once that gingival flap is open, you can put more on the bone, you can put some more, just don't go over your total amount. So there are blocks. Now, also during procedure, you can do some CRIs. And if you're comfortable doing those, there's some really good combinations out there. A lot of times we look at ketamine because that really helps with the MDMA receptors, and adding a small amount of fluids with a loading dose, and then kind of like a fluid bag, so much per hour into the IV line to help out with this with the pain that will be happening during surgery. Sometimes you can use lidocaine, sometimes you can use morphine. The MLK protocol is a common one. Just be comfortable with what you want to use and the products you want to use. So you don't want to start out with a heavy CRI on an older dog that's compromised the very first time. So maybe you have a fracture on a younger dog, try it out then. You can utilize your opioids, some in both dogs and cats, hydromorphone, fentanyl. There's a really good resource called the Veterinary Anesthesia and Analgesia Support Group, VASG.org, that has CRIs in there. It has specific diseases and what you need to do, specific compounds and how to work with these. This is not done by an anesthesiologist, but I have a number of anesthesiologist colleagues that are impressed and agree that this is some good information for people practicing. So you've got them through the operative stage. Now what do we send home? Remember, for tumors, I prefer to do piroxicam, and I might have to compound that out. Make sure you do your NSAID washout. I like buprenorphine for mucosal absorption in cats. You can give the 24-hour injection. Just remember, if there are any issues, there's going to be a longer-term adverse event. I haven't experienced that too often. Gabapentin, I can add it into other medications for chronic pain, and we'll talk about that in a bit. I certainly love it for your fear-free protocols for cats before they come in. I'm not a fan of tramadol for pain in dogs. Only about 10% seem to have any effect, and they really don't have the enzyme system to transform tramadol into an active metabolite. It's actually somewhat effective in cats, but it doesn't taste real good, so I doubt you can get it in many. But we have many options out there that we will get a personalized analgesic protocol for each patient. Also think about other things other than drugs. We want them to avoid self-trauma, so certainly an e-collar or an inflatable one, whatever cone of shame you have to use, but we don't want them re-injuring the facial surgery. Trazodone may be a good thing to send home, especially with pets that are quite active. I love cool compresses. Using something, a washcloth that's been wrung out, wet washcloth in the freezer, bring it out, let it soften up, and using it as a cool compress. And Robin just helped me. There is some gabapentin short-term after acute painful interventions, lots of papers from the human side, usually in conjunction with other things. So we do like our gabapentin, and we love our trazodone. We also really like our CC loop. So as we've been working with this CC loop for back pain, for back surgeries, for chronic pain, why not for the head too? It's an area that has pain, has inflammation. There's good post-operative protocols, and I've considered it for some of my long-term issues. Even with chronic pain and acute pain, acupuncture and other complementary therapies, whatever makes that patient feel better is a good idea. So what if doing the surgery wasn't the end-all and be-all for getting rid of pain? I see a good number of patients these days, my chronic stomatitis kitty cats, that even after we do full mouth extractions, we still have some moderate inflammation, some that have significant inflammation that continues. I don't know if we're getting a more active stomatitis, maybe the calicivirus is hotter, who knows, but I'm seeing it in younger patients. I used to be able to get by with caudal mouth extractions more. I seldom do caudal mouth extractions usually, and now I'm doing full mouth extractions on these cats, and I'm still having some that we have to manage post-extraction because that inflammatory, the host immune system is still hyperactive. We certainly need to make sure that they're eating well on top of everything. So a couple ideas around refractory stomatitis out of Wisconsin. They've tried using the 25 to 50 milligram daily doxycycline, depending on the size of a cat. You can compound it in some small chews. And at our practice up in Flower Mound, we were having some variable results. When it worked in a particular patient, guess what? That was their N of 1. That's what worked for that particular patient. Certainly with chronic pain, using the higher doses initially, but even in a chronic pain situation, starting at a low dose at night, I usually start 2 to 3, sometimes up to 5, see how sleepy it makes them, and gradually increasing up to 10 milligrams per kilogram, even up to twice a day. From there, with the osteoarthritis cases, you may have been using larger doses. You do what it takes to make the patient feel better. And remember, some of our dental pain could be related to a neuropathy of sorts, and that's where the gabapentin may make a big difference as well. Now, there's a product that's called 1-TDC, that's an esterified fatty acid in a little snip tip. It has the esterified fatty acids in it. It's like a little heart-shaped E vitamin capsule that you squirt onto the gums themselves, and that can help bring down some of the inflammation. It's also on its label for joint health. And I've also used Duralactin Feline in some of these cases, where the Duralactin, the microlactin, can help slow down the inflammatory progress. That's kind of interesting. Remember the Burmese with FOPs? Certainly, you're going to take care of the dental issues. You're going to try to reduce the stress, get rid of the triggers. But if it still seems to be painful, using NSAIDs and corticosteroids have basically not been that helpful, limited effect. And then when they're off of it, they go right back. What seems to be more helpful with these pets is a phenobarbital dose, which tells us there's something going on neurologically. Now, we do have diazepam there. I don't like it for cats necessarily. I might go to the gabapentin as well. But as we look at these, it's an unique syndrome. You might not see it, but now you know about it. What about that cat that had the injury? And this is one that we had a TMJ luxation. And initially, after replacing the TMJ joint and reducing the luxation, we use sewing buttons to help keep the cat from opening its mouth too far. So we still get a little bit of motion to help exercise that joint, but not far enough that they can reluxate. And in fact, this is a sewing button on the upper left. There's one on the upper right. And we have suture material, heavy suture material coming in basically inside the oral cavity. And then we tie it down to a ventral button underneath the chin. We also have our transmalleohyoid esophagostomy tube here, which is really good. This was a fracture kitty as well. So if we have injury to the TMJ at any point, whether it's luxation or previous fracture, whatnot, we can get osteoarthritis and ankylosis. That means we're going to probably have a range of motion that decreases, discomfort, maybe some grinding or clicking. Sometimes you can hear it with your stethoscope. And if it is severe, probably need some advanced imaging to determine how bad that TMJ joint is affecting the range of motion. And if there's osteophytes or things, might need a condylectomy. So again, and this is, if I could get Dr. Robin to just do this talk, she does it all the time. Chronic pain, maladaptive pain, that wind-up pain, where it went painful without being addressed early on. Certainly long-term NSAIDs, supplements, whatnot, gabapentin. I talked about starting out slowly, then gradually increasing. When you're going with a slow increase, we don't like to stop it abruptly, but as much as we love it, and even for that preoperative visit for kitty cats, in some states, it's becoming a scheduled drug because of humans, bless their hearts. So we need to look at all of our options. And I mentioned the loop earlier, that we have the regular loop that we can think about physical treatment with a targeted pulsed electromagnetic field. There's studies with osteoarthritis, with post-surgery. We're looking at some case studies with dentistry. And as we look at the loop therapy, what happens, it can help increase blood flow and modulate the cytokines. So we get a decreased pain, increased healing, decreased edema. It works through the nitric oxide production. As we look at how we actually implement these loops, this field comes out as a coil. We have the coil and then the treatment field. It looks like a barrel. And the area that you want to be treated needs to be within this field itself. The treatments last for about 15 minutes, usually automatic shut off. And then we like to wait at least 2 hours in between. But when I have my post-operative, I like to go at least twice a day initially. Some of my stomatitis kitties, I've had them do up to 4 times a day. So the studies primarily have been with hemolaminectomies post-operatively, showing a faster return to function, decreased pain perception, decreased opioid administration, increased wound healing. So lots of information on the human side. We're getting information on the veterinary side. And as we look at total patient care, this is one way we can help with their pain, inflammation, and healing. Now we've got the Assisi loop lounges that can be used for the smaller animals and the larger animals that are rechargeable. Kitty cats that are difficult to manage, putting something over a painful area or post-operatively or oral cavity, this may be the way to go, because you can either put them in the carrier. With my old man who has some osteoarthritis, when he's taking his nap, I just kind of slide the little mat underneath him and give him his treatments that way. Now we've got the specific dental loop, and we can use this loop with the bonnet. This has been devised for a short-term application, up to 60 treatments, slightly smaller loop for more direct application to the head or oral cavity. Again, when switched on by button, this has 15-minute treatments, and you can sit there and hold it next to the pet. Or there's a bonnet that's been made that looks like an e-collar with different areas that you can position the loop with the bonnet to apply the field to the surgical site or to the site that needs healing. So if you have a really patient, you can sit there with them. If they're sitting there beside you on the couch, you may be able to hold it by them if they don't like using the bonnet. Or you can set up the bonnet. There's several videos on Assisi's website that shows placing the bonnet with a loop placed in a direction that will help heal the oral cavity. And then you remove the bonnet and replace it with a loop already in place for subsequent treatments. So as we also look at inflammation, remember I talked about that, and pain from inflammation, but even inflammation as part of a systemic issue, a systemic disease, aging process. When we look at host issues in the oral cavity, one big thing that has been used in the past has been a low-dose doxycycline with humans. It's used occasionally now, but you have to keep it up for quite some time. So this is using doxycycline for its anti-collagenase properties given orally. That's why it's used in some of the stomatitis protocols. It's why it's used in doxyrobe underneath the gum line, not just for the antibacterial properties, but for the anti-collagenase properties, because part of that inflammation is from the overactive host response. And certainly with some stomatitis and other issues, there are different regimens for using cyclosporin. With the duralactins, I mentioned the microlactin that helps with the inflammation with the overreactive white blood cells. And then with the 1-TDC, used for both the oral inflammation and osteoarthritis. The key is, as part of healthcare givers, we need to remember to manage the pain during all aspects of our pet's experience. With dentistry, we're usually focusing on the surgical time. So we're looking at preoperative, both sending home things that they can use before they come in to help with the anxiety, NSAIDs to help with the inflammation and pain, maybe antibiotics if there's severe infections. Then certainly with our pre-anesthetic protocols to help with both sedation and anxiety and pain. Going with our things during the procedure, the blocks, the CRIs, tissue handling, whatever we need to do. And then sending home anything we need to do to help keep that analgesia protocol working. From post-operative medications to the pulse electromagnetic field, to cool compresses. And we're going to use whatever is appropriate for that particular patient for as long as we need to use it. Because when we provide that analgesia, when they get the relief from this discomfort or pain, They're going to have better function. They're going to eat better. They're going to be able to groom themselves better, which is a huge issue in kitty cats. And they're going to have a better quality of life, which is a huge portion of what we try to do when we're looking at all of our patients. And for me, especially, it's a big term that we talk about when we're looking at our older patients.